Welcome, everyone. I'm Dr. Chris Benton from Rocky Mountain Cancer Centers. I'm here with my partner, Dr. John Burke. We're having a discussion today about the latest and greatest from the American Society of Hematology annual meeting 2022, which occurred in early December last month. We're going to talk about some of the hottest issues in lymphoma as well as chronic lymphocytic leukemia with Dr. Burke. Dr. Burke, let's go ahead and get started. Can you tell me what's new and give us a summary of lymphoma and chronic lymphocytic leukemia at ASH?
You got it. Thanks, Chris. There was a lot of exciting new data in lymphoma. I'm going to cover mantle cell lymphoma, follicular lymphoma, aggressive lymphomas, Hodgkin lymphoma, and chronic lymphocytic leukemia. So kind of a whirlwind tour
Great.
in just a few minutes. So the first trial I'll hit was called Triangle. This was in mantle cell lymphoma, and this is really a potentially practice-changing study for patients with mantle cell lymphoma. This trial was conducted in Europe, and what they tested was in younger patients who are candidates for high-dose therapy and so-called stem cell transplant, which is part of our standard program in mantle cell lymphoma. They tested whether patients should have an oral drug called ibrutinib, which works as a so-called Bruton tyrosine kinase inhibitor, BTK inhibitor, added to their chemotherapy program. And they tested whether that improves outcomes. And sure enough, what they found is that when patients had ibrutinib added to the program, they had a significantly lower risk of relapse and prolonged remissions compared with those who did not have ibrutinib as part of their treatment. So that was the most important finding. And another important component of their findings, which is still a little bit premature, but is that if patients had ibrutinib added, it looks like the transplant itself didn't provide much in the way of extra value. That is, the trial raised the question as to whether patients even need the transplant at all, which is the most toxic component of the treatment program. And so that's going to be an issue that's debated moving forward, is whether these younger patients even need the transplant anymore if they have the BTK inhibitor ibrutinib added into the program. So that was a really exciting study. Yep.
So this is just an oral medication, and
Right.
just the addition of this to the existing therapy
Yep.
offered all of this benefit.
Yep.
Great.
And they started it with the initial chemo, and then they continued it after the transplant as part of maintenance. So it was people stay on the pill for a long time. Another exciting technology is what's called bispecific antibodies, and we are seeing a lot of data about these bispecific antibodies. The way this works, the bispecific antibody has one arm that binds to a protein on the cancerous B lymphocyte, but then another arm that binds to a protein on the non-cancerous T lymphocyte, and it stimulates the T cell to attack the malignant B cell. So this is a new mechanism. It's big. There's a lot of bispecific antibodies being developed in cancer treatment. As you well know, in ALL, you use these already, and now they're moving into lymphoma. And so we just saw the approval of one called mosunetuzumab in patients with follicular lymphoma, and we saw data here on a new one called odronextamab that looks equally promising in follicular lymphoma. Odronextamab had an overall response rate of 82% and a complete response rate of 75% in patients with heavily pretreated follicular lymphoma. So a great new option for patients, and we hope this will become approved by the FDA later this year. Moving on to talk about aggressive lymphomas. One aggressive lymphoma that's not real common, but we do see it, is so-called primary brain or central nervous system lymphoma. So some patients will get lymphoma that starts in the brain, and we treat those with intensive chemotherapy. And the question has always been, should we or should we not give high-dose therapy and stem cell transplant to these patients? So a group of investigators in Europe tested this, and they found that patients who got a stem cell transplant as part of their program did better, had higher survival rates than those who did not. And so, in my opinion, this really solidifies the practice of giving a stem cell transplant to patients who have primary brain lymphomas who get into a remission with their initial chemo. They reported an exciting result, which is that 3-year survival rate of 86% and progression-free survival 79%, meaning almost 80% of patients were alive and in remission 3 years after going on this study. So really good results for patients with brain lymphomas. Another super exciting study, or group of studies actually at ASH, was testing a new technology that allows us to detect DNA secreted from lymphomas in the blood. And we can use this technology to determine whether patients treated for lymphomas have achieved a remission and whether they're likely to relapse. And the technology is called phased seq. And so, really exciting, better than any previous way of detecting DNA in the blood. And they showed that patients who had no detectable DNA in the blood at the end of treatment had a very low likelihood of relapse, whereas those who had detectable DNA in their blood at the end of treatment had a much higher likelihood of relapse. So, and then actually this test looked better than PET scan at predicting whether patients were likely to relapse at the end of their treatment.
So a blood test is better, maybe better than imaging. When do you expect that this test might be available for use in patients?
It's not available right now. There are alternative ways of testing for tumor DNA available, but this particular technology is not available, and it's going to have to go through some more study, I think, before it becomes sort of readily available for routine use. But stay tuned, because this, I think, is going to be the future in how we follow patients with large cell lymphoma. Bispecifics are also big news in large cell lymphoma. Before, I mentioned them in follicular lymphoma. We're seeing a lot of great data emerge in large cell lymphoma. Just to highlight one of them was odronextamab, which showed overall response rate of about 50% and complete remission in 36%. We've seen similar results in patients with two other bispecifics at previous meetings. And so we expect that, or we hope that, several bispecifics may become available in 2023 for patients with relapsed large cell lymphoma. Moving on to Hodgkin lymphoma, there was a study that we were involved in that tested replacement of one of the chemo drugs called vinblastine with a new relatively new immunotherapy drug called nivolumab. And so that tweaked the initial therapy that we give to patients with Hodgkin lymphoma. This trial was exciting for a couple reasons. One, we got good results with the majority of patients going into remission. But another interesting thing was that we really changed the toxicity profile. That is, we saw very little in the way of infections, hospitalization for low blood counts, and fevers, which do occur with the conventional way of treating Hodgkin lymphoma. In contrast, we introduced some side effects that one can get from these immune stimulating drugs, things like thyroid abnormalities and skin rashes. So we saw some different side effects, but less sort of dangerous, less severe side effects than what we typically will see. Not ready for routine use, needs to be compared with the standard in a randomized trial that has not been done yet, but stay tuned. We think that's a promising regimen. And the last study I'll highlight, it was in chronic lymphocytic leukemia. This is a trial called Alpine, and it compared in patients with relapsed CLL the older BTK inhibitor called ibrutinib with one of the newer ones called zanubrutinib. We've seen a hint of this trial presented before, and this was longer term follow-up data, and it confirmed a couple things. First, that the rate was a little higher with zanubrutinib. Second, that patients who get zanubrutinib stay in remission for longer than if they get ibrutinib. And third, that the toxicity profile of zanubrutinib is a little more favorable. They saw lower rates of the cardiac toxicity, atrial fibrillation, which is a heart arrhythmia. And so that's a plus for patients to have lower risk of this heart arrhythmia, which we know to be an occasional side effect of these BTK inhibitors. So the take-home point here is that if you have a patient with relapsed CLL, it's probably preferable to pick one of the newer BTK inhibitors as compared with the older ibrutinib. But if you're on ibrutinib and you're doing fine, stay on it. You don't need to change. I think that's what most people are doing. So
Fantastic. Well, thanks a lot for sharing all of those great insights on lymphoma and chronic lymphocytic leukemia. I appreciate it.
thanks, Chris.